is Bryan. I'm a clinical anatomy fellow with the Seattle Science Foundation. And so today I'll be talking about cranial nerve foramina. Before I start, I just wanted to get you guys to appreciate the vastness of this topic. It's a massive topic. My paper on this is over 26 pages long with near 100 references, so I have to split it into two papers. So this talk is very condensed into 10 minutes. So my goal today isn't to get you to memorize like the little details of what goes through the holes and stuff. It's just to get you to appreciate that there's very significant things happening in the foramina. And fractures can happen, tumors can grow within the foramina that can cause various pathologies. So let's begin. So I'm going to grab my friend here. So during my research, I stared at this for weeks and weeks. So hopefully I can point out some interesting things to you guys. So this is a skull base. As you can see, there's many holes in it. So the holes in bone are called foramina. This is broken up into the anterior section, the middle section, and the posterior section. So we'll start. So the overview of this, these are the different cranial foramina we'll be talking about. So first let's talk about the Cribriform Foramina. So the Cribriform plate is the one that's embedded right in the frontal bone. It has several, it has many different, so it has many foramina in it that are less than 1 millimeter in diameter apart. So it's interesting is as you age, these foramina will get smaller and smaller. So so after 50, it was compared to maybe like a 25-year-old that it's over it's over 1 centimeter squared less of free space. So it's quite significant. So the main thing that passes through this is the olfactory nerve branches, so for you to smell and things. So as you age, that's one of the reasons postulated that the sense of smell isn't as strong as when you were younger. So there's various pathologies that can affect the foramina, such as schwannomas and meningiomas. And the clinical thing is interesting because typically the main complaint is not a lack of smell, because it's not something that we regularly pay attention to. So a gradual decrease in smell is not really noticed as much. So usually you would notice like headaches, and you can have seizures and some personality changes because of the proximity to the frontal lobe, responsible for different personality traits. Can like that. The next one we'll be talking about is the optic canal. Optic canal sits right here, if you guys can see it. So the main thing that passes through the optic canal is the optic nerve with the ophthalmic artery. And as you can imagine, so if there's an artery passing through something, you can imagine that an aneurysm of the artery can cause blockage of the foramina itself. So you can get blockages of the optic canal with an ophthalmic artery aneurysm. And again, meningiomas seems to be like the main culprit for masses that can block the foramina. And again, there's a bunch of other causes like fractures and things. But the clinical findings that you would find is just impingement of the optic nerve. So you get blindness, loss of color vision, decrease in visual fields, things like that. The superior orbital fissure is a very neat guy. So he's in the middle fossa. He kind of looks like a hockey stick. But so it can be separated in 3 parts by the tendons of the extraocular muscles. So the tendons can divide into 3 parts that are listed here. I won't go through in too much detail. But the main things that pass through it is basically the nerves that innervate the eye muscles, like trochlear nerve, oculomotor. Then you have the different vessels, like the superior ophthalmic vein, and so on. So there's actually a known syndrome that's caused when this foramina is blocked. It's called superior orbital fissure syndrome. And then so that's caused when you impair the nerves coming out of that foramina. So you get unreactive pupil, ptosis, proptosis, ophthalmoplegia, and you can get also some anesthesia of the upper eyelids and things. Do you guys remember what's responsible for ptosis? Like what mixture? So there's kind of two main things. So, yes, perfect. So, so yeah, so the oculomotor will innervate the levator papilla, and then the tarsalis muscle will be innervated by the sympathetics.
A good question that people ask is which one of those ptosis is more profound, a sympathetic ptosis or a third nerve ptosis? So third nerve, yeah. So the whole eyelid will be completely closed with the third nerve, whereas a sympathetic is mildly compressed.
Cool. Next foramen we'll go to is a foramen rotundum. This guy is responsible to carry the maxillary branch of the trigeminal. So it's interesting because in this research paper what we did is we compared the cross-sectional area of the structures going through the foramina with the foramina area itself, and then so we can calculate like, the amount of free space within the foramina. So in this one, there's approximately 3 to 5 millimeters squared of free space, which is very, very small. It's like maybe this. So any mass greater than that size can theoretically cause huge problems. With this, the main pathology is trigeminal neuralgia. And in lab one day, me and Joy were doing a dissection, and then this is this is a trigeminal ganglia. And then, so you can see the different branches going into the different cranial foramina. I just thought that was interesting too. So the next one is a foramen ovale. The main thing coming through this foramina is a mandibular nerve, the middle meningeal artery, which is a big guy, and the lesser petrosal nerve and some veins. So the middle meningeal artery is quite important. It innervates a wide area of your brain. So different pathologies can cause blockage of this foramina. You can get squamous cell carcinomas from the skin, from the lungs can spread adenoid cystic carcinoma and non-Hodgkin's lymphoma have been reported. So because you impede the mandibular nerve, you can get muscles of mastication will start to atrophy, and you get facial pain as well. And because of its proximity to the cavernous sinus, so the cavernous sinus would sit very close, just in between here. So because of its proximity to the cavernous sinus, you can get something called cavernous sinus syndrome, which affects the nerves going through the cavernous sinus, which is 3, 4, and 6. And Dr. Tubbs was in a paper some time ago that involved a procedure using the foramen ovale to block the it used to treat symptoms for trigeminal neuralgia. So in the posterior fossa, we come to the big guy, Foramen Magnum. So this is one of the few foramina that differ significantly between males and females. So the males are a lot bigger than females. So the size difference is about 1 centimeter squared in space. So going through here is the medulla, the surrounding meninges, and the vertebral arteries, specifically the V4 segment and the spinal roots of the accessory nerve. So with this being the biggest foramina, it's been researched heavily in terms of different pathologies that can cause occlusion of it. So there's a long list, I won't read them all, but again, meningiomas is a big one. Something to think about is achondroplasia. That's an interesting one as it causes constriction, as it causes bone growth inwards. So it can close the foramina gradually. So when you close this section, you can get hyperreflexia with drop attacks. That's sudden loss of consciousness where you just drop, and that's because you're constricting the vertebral arteries. You get gait instability because, again, the brainstem is running right through there. The sleep apnea because of the respiratory centers might be compressed. Hydrocephalus, as you block the outflow of CSF, your brain just... And also loss of urinary and bowel functions involved in the autonomics. Hypoglossal canal. This one's very straightforward. Basically, whatever's gonna so your tongue muscle is gonna be the clinical outcome if this is obstructed. So going through this is the hypoglossal nerve, as well as some arteries, meningeal branch of the ascending pharyngeal. So the interesting about this is that there's a lot of free space in here compared to the other foramina for some reason. There's 6 millimeters squared of free space. I mean, that's not a lot in general terms, but in terms of the other foramina, it's one of the most abundant amount of free space you have. So as I said, you get tongue atrophy, fasciculations, deviations, and dysphagia. Do you guys remember what side the tongue would deviate if you have a lesion on that side? So say that I have a lesion on my right side. What side would the tongue go? Nice. So we have 2 more. Jugular Foramen. This is one of my favorite ones because there's so much things involved with it that I wish I can go into a lot of detail with you. But the main things going through it is cranial nerves 9, 10, 11, the tympanic branch, and the auricular branch of 9 and 10, and also several arteries and veins. But the cool thing that I found was this syndrome called Vernet syndrome. So that's when you have compression of cranial nerves 9, 10, 11, which is very strange clinical finding. So the person will have trouble shrugging their shoulders because of loss of cranial nerve 11. But they also have loss of taste in the back of the tongue, loss of gag reflex, you have hoarseness in the voice, dysphagia. So anytime you see in the clinic someone having trouble raising their shoulders plus a weak hoarse voice, you just maybe think about this. And our last foramina is the internal acoustic meatus. This is where the intracranial part of your facial nerve will run through, and your face is very important. That's the moneymaker right there. So so if you impinge the internal acoustic meatus with osteomas are quite common of the auditory canal. You can get hearing loss of balance because also running through the foramina is cranial nerve 8. So again, you can get a hearing loss with that. Loss of balance because of the Levin structures are in that area. The inner ear structures are in that area. You also get hyperacusis, which is it's a higher pitch. So usually the stapedius muscle will tone down the pitch of sounds. But if that's not functioning because that's innervated by cranial nerve 7, then things will seem really high pitched to you. Thank you. That's all I have.